Hi, Akanksha, are you there?
Hi, Dr. Giri. How are you?
Hello. Good, good. So I'll
Thank
just,
you very much.
no problem. Yeah. So I'm just going to try to get the path presenter on. Oh, it
Okay, sure.
says host has disabled
Yeah,
participant.
let me make you co-host and you should be able to. Now you should be able to share the screen.
Okay.
Meanwhile, let me introduce you to our group.
Yeah. So why,
I
why can't I pull the path presenter?
so if you go to pathpresenter.net,
Yeah, I already opened that.
okay, are you registered?
Yeah, I already opened and it was on my screen.
Oh, so you're not able to share the screen of that thing.
Yeah.
Okay, so if you share the screen, it will show you different windows to share. One of the windows might be Path Presenter. See the Chrome or Internet Explorer, whatever you have it on.
Maybe I'll just minimize the screen and, you know.
If you bring it, if you have two
Oh,
screens,
okay. Can you see now? Or-
no. If you have two screens and if you bring it to a different screen and then share the screen, probably that might work.
Oh, okay. Yeah. Now
Right.
you can see it now, right?
Yes, yes, yes.
Oh, okay, great.
All right, great. So let's get started. I'll introduce you quickly to our group.
Okay,
Welcome,
sure,
Dr.
sure. Yeah, go ahead.
Yes, yes. Welcome, Dr. Dilip Giri. I am so glad that he was able to join, and he is very kind person. I have heard very, very good things about him. He is from my parent institution in Sloan Kettering. He has been practicing in Sloan Kettering in breast pathology since I think 2007, and I really, really look forward. We really look forward to learning from him.
Okay, great. Thanks, Akanksha, for the kind words. I don't know where you got the very nice person from, but
No, yeah, I've heard a lot of like you have a good, very good reputation, Dr. Giri.
okay. So I think let's get started. I know we have a lot of stuff to get through.
Yeah, yeah.
This is a very tricky way of doing things. Because I do realize, I mean, I had a quick look at some of the images that we have on Path Presenter. So, you know, we have to work with whatever we have. Now,
Hmm.
you know, in ideal world, we would like to do it differently, but hopefully um, there will be a lot of discussion and, you know, we can address some of the questions in discussion rather than actually, you know, via illustrations of
Hmm.
cases. So I understand that, you know, my presentations have been divided into 5 different parts.
Yeah, that was just like a brief overview of what we can
Right,
do.
right.
It's
So it
not a
looks,
hard and fast. Yeah.
yeah. I think yeah, but it makes sense. I think it probably better to do it in some kind of a systematic way. So
Right,
I
right.
think the first topics that we will try to address today are essentially, uh, you know, non-cancer things, benign proliferations. There is some discussion I think we will do also on DCIS. And I think no discussion in breast pathology can happen unless and until we talk about how on earth do we distinguish ADH from DCIS, or for that
Right.
matter also how on earth sometimes do we distinguish UDH from EDH. So although when we look at the books and all and read papers, it seems like everything is in black and white, and that there should not be really any room for agonizing and difference of opinion. But in reality, even today, we as the breast group at Memorial, we are like 15 breast pathologists working here. And in our consensus meetings that occur twice a week, this is invariably a subject of discussion. People bring cases and ask whether majority would call this ADH or would they call DCIS. So I think that this is a never-ending saga, really. So now, given that one of the, we'll have to kind of, I think, surf through all these images to try and pick up some of the ones that are going to be part of our discussion. So on this first screen, I see an image on collagenous spherulosis. So let's talk a little bit about that. So this is okay, right? I can just pick whatever I want and talk a little bit about that and move on, right?
Whatever you want is fine. I mean, you could, there is also a search button in there. If you want to go systematically and search in there, you will find all the cases that you search. For example, if you search a DCIS, it will show you a few cases of DCIS that that you might want to show. So, I mean, whatever works for you, it works for us.
Okay. Yeah. So let's first, we will try to do the search in a minute. But I think since we have this up on the screen, let's start with something that is somewhat easy. So here is a nice picture of a benign, essentially a benign kind of, this is a somewhat expanded lobule. And these acinar spaces have now become bigger. So someone would, want to call something like this as blunt duct adenosis. It really doesn't matter what you call it as long as it is benign. But I think the focus that we are going to put ourselves into is this particular thing, which looks vaguely cribriform, and these spaces look quite uniform actually. So the question would be, is this like a cribriform type of lesion? Now on frozen section, something like this could be very tricky, you could, especially if you are not familiar with this entity and have not seen this for a while, you could get into a trap and call this like something like DCIS, So normally these days, this would not be a problem because frozen sections are not done really for primary diagnosis of breast lesions. I mean, as you all know, we depend on core biopsies for a definitive diagnosis of any breast lesion prior to any kind of surgery. But this could sometime crop up. Let's say they are doing a nipple sparing mastectomy and they send a piece of tissue from the nipple base, and God forbid, some such change has happened in the vicinity of the nipple, and you have this kind of cribriform thing. This could be a pitfall, although it's really a very far-fetched scenario, but I'm just raising for you possibilities where, something like this, as benign and as uninteresting and inconsequential like collagenous spherulosis could become a challenge actually. So I think what we see here is that these spaces are actually filled with some material, right? I mean, this is collagen material. So this is all produced by the basal lamina of the myoepithelial layer outside of these individual ducts. And oftentimes this will undergo degenerative changes. And when that happens, this will become like empty spaces. I think some of that is beginning to happen here, as you can see here. But even in these instances, what you will see is that there tends to be a very fine kind of membrane, basal lamina-like membrane. And this sometimes get lifted actually, artifactually. So you will have like a bridge of this kind of, membranous kind of stuff crossing along this, space. So this is essentially a product of some myoepithelial layer. Some people might want to think that this is some kind of a myoepithelial lesion, actually, collagenous spherulosis. And sometimes you may see these changes actually in the vicinity of adenomyoepithelial lesions or myoepithelial lesions. In core biopsies from those kinds of lesions, especially at the periphery, the core biopsy may sample something like this in addition to the main lesion. And therefore, the association between myoepithelial cell and these lesions, I think, is supported. So I think other than not mistaking this as DCIS, I don't think that these pose much of a problem, really. Of course, you also need to remember that although in this particular image, this happens to be a collagenous spherulosis purely within a ductal, within a duct and showing ductal proliferation, occasionally collagenous spherulosis might involve foci of LCIS. So those can also be troublesome. They can be calcified, so they may be picked up on mammography. So this can be an unusual source of calcification on mammography. The occurrence of collagenous spherulosis in association with LCIS is rather unusual, but it does happen, and you have to keep that in the back of your mind. And this becomes important. Why does it become important? Because as we all know, one of the stain that we use in order to distinguish usual ductal hyperplasia and DCIS or ADH is ADH5 or CK5-6, right? So let's say while it will work when the proliferation is purely ductal, if, for example, the proliferation is of lobular carcinoma in situ or lobular cells, then using CK5-6 will not help because the CK5-6 will be negative in that situation, and you will probably then end up calling something like that as DCIS, if there are multiple such foci in the same area. The stain that really you need to use in making that determination obviously is ecadherin, because that will confirm for you the lobular phenotype of the proliferating cells. So these are some of the finer points. I mean, it's quite unlikely that you will run into this every day, but in some unusual circumstances, you might have to make that determination. Now, since I practice breast pathology all the time, this is not so much of a challenge to me or to my colleagues, Now, I think while I'm speaking, I welcome any one of you who wants to make any comments or raise any questions to do so we can address while I go on. Okay, if there are no questions on collagenous spherulosis, we will move ahead. And now let me try the search. So why am I not getting this? So where do I get the search? Akanksha? I think you are muted.
You have, yeah, I am muted. So you go to the adjacent window. You see the other one? Yeah. Yes.
Oh, okay. And then I just type here?
Yes.
And it doesn't have to be in caps, right?
Nothing, yeah.
And just enter it?
Yeah.
Oh, great. Okay, wonderful. Okay. So let me first step back a little bit and let's talk about ADH. Let's see if we have ADH here. Okay. So let's start with this focal ADH, whatever that may be. Let's see what exactly it has in the image. Now, admittedly, some of these images may not be ideal. So for example, something like this looks very unimpressive, right? So let's see if there is really any ADH here. So as you can see, I'm having a hard time finding any ADH in this, right? So, I mean, while I'm not trying to be critical about the image, we may have to take some of these, with a pinch of salt.
Yeah, I agree. There
So
might
now
be.
let's focus. So, so how this can become tricky, right? I mean, obviously this has been posted as an example of focal ADH, right? I mean, to me, this is just UDH really, So again, there is like, already I am dissenting, So it just illustrates. Now, whether I am right or wrong, that's not the point here. The point is that even after all these years, we have been doing morphology for now nearly 100 years. Even after that, in breast, this really is something that refuses to go away, this, the bone of contention. Now, to me, all these cells are jumbled up. We can't go any higher in terms of magnification. But as you can see, these cells are all jumbled up. They are overlapping, some of them. There is uneven crowding. And even in the other one, the other core, so very unimpressive changes here, really. And the stuff here, all this thing that is projecting in the lumen, looking kind of micropapillary. So look also this, how irregular this is, right? I mean, this is like jagged. Again, the cells are overlapping and, they're not respecting each other, right? So generally speaking, in ADH or DCIS, low grade, the cells will be kind of uniformly distributed. They will be spaced apart. They will respect each other's territory. They will not try to crowd over each other. And also this kind of projection, this jagged kind of, irregular. So generally in ADH and all, they tend to be smooth and uniform, elongated, smooth. So to me, this, this is really not even ADH. And also, if you notice, some of these nuclei are darker as they go to the surface. Even here, they seem to be flattened. So that is all what we refer to in our jargon as, a maturation, attempt towards maturation. So all that points to actually, the fact that this is more likely to be maybe minimal UDH rather than ADH. Now it is quite possible that in some other pieces of tissue, there was some ADH in it, but here there is nothing to suggest that we have ADH. And also look the accompanying changes. These are all very benign, right? That's another point to remember. One of the observations made by a very famous British breast pathologist, he is no longer with us, but in his days, he was one of the best names in Europe, Adh. Some of you may have heard his name. So Adh was a very interesting character. He wrote a wonderful book on breast pathology, which even today, is a pleasure to read after 50 years of it being published. So he made an important point. He said that when you have a doubt about whether this is ADH, UDH, stuff like that, look at the company that these foci keep. So if the rest of the changes look to you benign, right, the chances are that whatever you are debating is also probably benign. So look at the company they keep. These are the words he used. Now this also in human relationships also holds true, right? I mean, if you are in bad company, the chances are you are going to be a bad person, right? But if you are in the company of saintly people, that will rub off on you and you are probably going to be a saint also. Well, this is all in lighter, vein. Don't take all this very seriously. After all, there can always be instances where DCIS might suddenly crop up in otherwise benign kind of proliferative changes. But I think that still remains some sort of a useful guideline. And I always emphasize this point to my trainees. And I have used this in my own days, in early on in my career. Okay, so let's go to some better picture. Okay, so now we have another case, a diagnosis of ADH. So again, so the first thing you will notice is that ADH can come in different forms, right? I mean, they can be just like, single isolated ducts that are showing proliferative changes. And they are very small single ducts or maybe a couple of ducts with very low grade nuclei. And therefore, we don't want to call it DCIS and we end up calling it ADH. They may sometimes happen as changes within a papilloma, within adenosis, sclerosing adenosis, and a whole host of other things. So ADH is a very, you have to understand the context in which these changes are happening. So here, obviously, it is happening in some kind of maybe a papillary or an adenosis kind of a lesion, nodular kind of a lesion. Some of it is really sclerosing adenosis. Now, within that, there are some ducts that are showing a rather uniform proliferation of cells. So look how these cells are spacing themselves, unlike in the other case where they tended to crowd over each other, and they also look kind of alike, more or less. There happens to be also a mitotic figure here. So mitosis in itself is not diagnostic of anything. Although Rosen in his book, I think, makes this a point that if you see mitosis in a proliferative focus, ductal proliferative focus, then that's not something you should expect to be happening in benign type of proliferation. But I think that is not entirely true. You can get mitotic figures also in UDH. And for that matter, one should not also use the presence of necrosis within a ductal proliferation as a diagnostic feature. You can get necrosis also in usual ductal hyperplasia, particularly when it is a papillary type of ductal hyperplasia. Okay, so I think the most important thing is really the uniform nature of the cells and how they are nicely spaced apart, and whether they look somewhat hyperchromatic and atypical to you. I think that is an important point. Now, these changes are not sufficient by any stretch of the imagination to call something like this as DCIS. So I think it would be fair. I mean, most of the stuff here is probably benign, but there is some ADH. And also in this larger focus, a lot of these changes may actually be benign, but here and there you may see sprinkling of some atypical proliferation. So if you see some of these areas, these probably are benign. Look how these cells are arranged. Okay. So for something like this, you would say focal ADH. Now on core biopsy, this becomes important because if you mention that, only then a patient may get an excision. Otherwise, if the rest of the things are benign and you miss those kinds of foci, then the patient may be followed up. Okay, let's go back. So this is another presentation of ADH, right? So here, this is happening again, like a lobule, correct? And here, these acini are somewhat cystically enlarged. And this would be a typical scenario of what we would like to call as flat epithelial atypia or columnar cell change with atypia. So these cells, again, very low grade. There is these are hyperplastic changes, multi-layering. And in that setting, if we go here, this is something that I think that most of us will agree probably qualifies as a small focus of ADH, because although the cells are still the same, they are now clearly, they have proliferated beyond this level. So now they are throwing all these processes into the lumen, these micropapillary tufts. And see how these are smooth and elongated, unlike the jaggedy kind of things that we saw in that focus of UDH. And these are the same uniform cells, right? There is no attempt towards maturation or anything. This is the same cell type that is growing. And this is not still quite, so if this was left undetected, right? And I mean, if this happened to remain in the woman's breast long enough, then this process would continue to grow. And at some point, this would then culminate into low-grade DCIs. And generally speaking, the low-grade pathway will remain low-grade. So if that low-grade DCIs is allowed to stay without any surgery and the woman lives with it, for a few more years, and that is when the invasion will start happening. And the invasion in the background of this type of change is, at least in theory, and based on the molecular alterations, is likely to be low-grade invasive carcinoma, like, for example, tubular carcinoma or invasive lobular carcinoma or well-differentiated invasive ductal carcinoma. So it's unlikely that in the background of these changes, after they have culminated through or past DCIS, you will get like a triple negative cancer or anything like that, They will stay within the same pathway. Okay. Now, since we are talking about ADH and flat epithelial atypia, we have to also remember that ADH may not always happen against the backdrop of flat epithelial atypia. It usually does, but not always. Now, the tricky thing is that although the whole story of flat epithelial atypia began just before the beginnings of 2000, the year 2000, when Schnitt did his big study on the so-called nurses' health study in Boston, he was the first one to recognize that when he saw these changes in biopsies, I mean, all those biopsies were done for calcifications, and flat epithelial atypia typically are associated with calcifications. Now, what he recognized was that those women who had these changes, which at that time had no name, right? I mean, these were his early seminal observations. He realized that when these women had excision done after the core biopsy, a proportion of them had more advanced changes in the lumpectomy specimen. So by more advanced, he included in that TCIS, invasive carcinoma, and also I think ADH. And I think that was the basis for recommending surgery. Whenever there was a biopsy diagnosis of flat epithelial atypia or columnar cell change with atypia. So these terms are interchangeable. Columnar cell change with atypia and flat epithelial, they're the same thing. Now, so we saw many years of that happening, right? Over the last few years, several years, people are losing, this whole notion is losing steam, as it were. And people are becoming, they're kind of raising their threshold for what qualifies as flat epithelial atypia. Generally speaking, unless the atypia stands out, you don't even want to call it flat epithelial atypia, because otherwise that may lead to surgery, right? So at Memorial, actually, I don't know what is happening out there in the real world, but at Memorial, because we are a specialist center, we have excellent imaging support, and we have very proactive surgeons and all. So generally speaking, with a core biopsy diagnosis of flat epithelial atypia alone does not lead to any surgery unless the patients are at high risk. So if they have history of cancer, or if they are BRCA positive, or there is the changes are not concordant with imaging, only then there will be surgery. Otherwise, they are happy to follow these patients because the life history of flat epithelial atypia is very long. I mean, there is absolutely no reason why an 80-year-old woman should undergo surgery for flat epithelial atypia. Because by the time that progresses even to low-grade DCIS, the woman probably will be in her 90s, and in some cases may have passed away, for some other reasons. So that is how the management has changed over time. And in our group, we tend not to call anything as flat epithelial atypia unless we bring the case to consensus. Because unless and until there is substantial atypia, it's probably better not to call it anything. I mean, the problem is, where do you draw the line? This is all, an individual person may have a particular threshold, and this is a continuum, right? So one draws a line somewhere. So now if your line is very low down, then just about anything will be flat epithelial atypia. On the other hand, if your threshold is very high, then what you consider as acceptable to be flat epithelial atypia may actually be flat DCIS. So, I mean, I don't think that in a lecture like this, we can really address something like this, but I just wanted to give you some idea about this whole saga of flat epithelial atypia, how it all began, and how the management of this particular change seems to be changing.
So, Dr. Giri, I wanted to ask a question.
Yes.
So, if you're reporting ADH or low-grade DCIS on your margins, do they do re-excision at MSK, or how is it?
Oh, very good. Okay, so ADH at margin, we don't measure distance to margin for ADH, or even, I mean, certainly not flat epithelial atypia. DCIS, we will mention distance to margin. Now, the important number to remember is the distance less than 1 millimeter. So if the distance is less than 1 millimeter to the margin, only then it is of interest to a surgeon for re-excision. And even then, like, let's say there are 5 slides, right, of the margin. specimen, and there is only one slide that shows some DCIS, and the approximation of that focus of DCIS to margin is small, right? I mean, just this focal DCIS coming to within 1 millimeter, then they will probably ignore that, because most of these patients will get radiation for DCIS after lumpectomy. And going back is going to be low yield, especially if the approximation to margin is only focal and small volume. So it's like a case-by-case thing. So in another scenario, if there is a lot of DCIS in multiple sections of a margin specimen and multiple foci of DCIS are coming close, then there is a real chance of getting, some more DCIS by going back. So that is how, they handle these. Does that
Okay.
answer your question?
Yeah, thank you.
Okay. Okay, so let's move on. So again, so by now you will recognize that this is again some cystically, distended lobular units. So this would be what you would expect, and a very low power about whether there is going to be any flat epithelial atypia or not. And now you want to see whether there is really any ADH going on. So you start going higher power. So these apical snouts, this is all in the original description of flat epithelial atypia. But these apical snouts are just apocrine, indicative of apocrine kind nature of the mammary epithelial secretion, because this is going to then break off and fall into the lumen. That is why these are apocrine glands. Although this is not showing what we recognize as apocrine change, but this kind of snouting suggests the apocrine nature of breast epithelium, rather instead of like ecrine type of glandular epithelium. So again, as you probably have recognized, I'm having a hard time really finding anything, worrisome here. I mean, the only suggestion here of some, I mean, this is not even making really, I mean, is this really a bridge, right? I mean, I don't know. If you went deeper, maybe this will just go away and you will then have something like this. I mean, to me, this is probably nothing, it's probably not even flat epithelial atypia. Generally, you want to see some hyperplastic changes and real atypia. I mean, these nucleoli to me seem like the benign type. Now, occasionally you may get some atypical changes happening, while the rest of the things may not be really that atypical. Occasionally some foci may begin to look atypical. And so, I mean, how much importance to give to this? I mean, in my experience, certainly, at Memorial, something like this is not going to really generate much interest amongst my peers. People will say, oh, there is nothing. Okay, so certainly there is no ADH here. Okay, so now here we have a diagnosis of ADH. So the stuff that we are seeing here is mostly apocrine. So this is just benign apocrine metaplasia. And so, I mean, the whole unit is apocrine, right? I mean, there is no reason for ADH to happen here. This is where Azopardi's rule comes in handy, I mean, by association, this is all apocrine-ish kind of change, just a different texture or flavor to it. There seems to be like a little fibroadenomatoid kind of change happening in the background. So nothing much of interest really going on even in this slide. I hope I'm not upsetting some of you by just, summarily rejecting some of these.
No, I don't see it too. I mean, I wonder if like there were big excisions and wrong, like A12 versus A13 have been scanned or something like that.
Okay, so this is again, now we are talking, right? So this is a diagnosis ADH. See, look how it just stands out, right? I mean, we don't have much trouble in accepting this as ADH. These are nice uniform cells. They are respecting each other. They are making all these, structures, bridges. So this is a nice example of ADH. So this is now growing within some kind of a papillary type of, overall the unit is showing some papillary type of change. So all of this is really atypical, really. Now the question here really is, should we call something like this as low-grade DCIS or not? That would be really something that we should be asking ourselves, right? So again, if you show something like this to 5 different pathologists, it will generate different opinions. But I think this is very low grade, right? Most of us will agree that this is kind of low grade. And it's not fully developed, right? I mean, the proliferation is there, but it's not sufficiently, it has not, how should I say, it has not reached a sufficient degree that it could qualify as DCIS. So how do we make that? I mean, how do we deal with this, right? Let's ask that question first. So number one, in a core biopsy, if you are going back and forth and deciding whether to call ADH or DCIS and everything is low grade, it probably is not DCIS, right? And even if you call ADH on a core biopsy, the patient will get excision. So your purpose is served. You want the whole thing to come out. And that will give you more tissue, more changes to look at and to make a diagnosis in a better, informed manner. If something like this, you call it DCIS straight away, and the patient gets excision, and then the changes are really not much. Because many times the radiologists, they just somehow manage to remove most of the abnormal changes these days in the biopsy because their imaging techniques, their resolution has become so much greater over the years that they are able to pretty much even small things, they pretty much are able to remove almost all of it. So then there is not much remaining behind. Now in those situations, then the source of diagnosis of DCIS becomes the core biopsy. And the patient is stuck with that diagnosis of DCIS. So it may not seem much of a big thing to us, but I think for patients, it's a big thing. Like, nobody wants to live with this fear, and the anxiety that comes with the diagnosis of carcinoma. I mean, for us, low-grade DCIS may seem like nothing, but for patients, and then the patients also come in different forms. Some of them are hyper anxious type of people. They will go crazy, oh my God, I have DCIS, let me get a mastectomy, and then lo and behold, there will be a mastectomy for maybe nothing. So unfortunately, these are the things which we cannot really comprehensively talk. I mean, 1 hour, even 1 year maybe may not be enough to talk about all these things. But what I'm trying to tell you is that the way you approach core biopsy, like when you call something DCIS, it has to be absolutely, a definite DCIS. If it is low grade, then you want to look at the extent of changes. Are these really sufficiently proliferative? Is the volume big enough? So how do we determine the volume? So Page and others, many years ago, they came out with this rule of 2 millimeters or 2 ducts, which we, often use. But you have to remember the history of how that came about. So Page, when he came up with this idea, I mean, he was doing some kind of risk assessment kind of study. He was not using that as a strict diagnostic kind of rule. This was more like an epidemiologic kind of study. Thousands of cases were seen and the risk associated. That is how he decided the 2 millimeter thing. So now, if we conveniently grab that and start using it as some kind of a diagnostic discriminant, then that may not be the best way. Sometimes we have to use our judgment, like in an 80-year-old woman, I mean, how does it matter, right? You can tend to be more conservative. On the other hand, a young woman with BRCA changes and all, you are more worried, right? So you can be more aggressive, and definitely there should be more surgery and all. So that is how these things work. So anyway, to cut a long story short, this is a good example of what I would regard as ADH. Now, a woman like this may have DCIS actually on the lumpectomy. And the changes may be so extensive that she may end up getting a mastectomy because the margins may never come back clearly negative. And they may have to go back 2 or 3 times, and finally the patient may end up with mastectomy for even low-grade extensive DCIS. Okay. Highly atypical ductal hyperplasia. So this better be good, right? So, okay. So I think from whatever we have seen so far, right? I mean, clearly the changes here are most pronounced, right? I mean, multiple ducts are involved. The changes are multifocal. They are quite marked. So a lot of people may actually have the guts to call something like this even as DCIS. I mean, after all, if you go by the rule of 2 ducts or 2 millimeter, something is like this is definitely more than 2 millimeters, right? If you span this across. And yet, as you can clearly see, right, whoever has posted this feels that this is like highly atypical ductal hyperplasia. So is this person, he or she, is not willing to, go all the way and call this as DCIS. So that shows the dilemma, right? How people have different thresholds and things like that. And as I said, in core biopsy, it really doesn't matter that much because they will do an excision. Of course, you may argue that, okay, on excision, there may be nothing. So is this only ADH? Why this is not DCIS, right? So that would be really a tricky question to answer either way, right? So I think in cases like this, therefore, it's better to have more than one opinion. I mean, in an 80-year-old woman, what does it matter, right? I mean, low-grade DCIs, ADH is the same thing as far as that woman is concerned. You don't want to radiate her. But in a young woman, this could become tricky, right? If she is not adequately managed, her breast is at risk to get a recurrence or something like that. I mean, I'm quite worried, So at Memorial, probably, at the very least, something like this will be called as ADH with changes focally reaching or bordering on low-grade DCIS. Okay, let's see next. So Akanksha, we may not be able to finish, the stuff that, because the way I am going.
Don't worry about it. You are doing awesome, and I mean, I just want to
so we
keep
will
on
keep
listening
this
to
like,
you.
we will keep talking,
Yeah.
maybe I'll come
Yeah,
back some other week, and then we can just continue.
of course. Yeah, if you have time, that would be really great. You take your time. Don't feel rushed. I mean, this is the best way to learn. You're telling us the real world things, and this is what is important.
Okay, so now this one is like papilloma with ADH or something like that, right? I mean, that's what the core biopsy diagnosis. Okay, so it is a papillary thing, right? I mean, we are seeing duct, which is showing all these, kind of highly nice fibrovascular core. So it's a papillary kind of growth. And so there is, these cells look somewhat monomorphic. So, I think ADH is fine. Really the changes are not enough, right? I mean, we can't really go beyond ADH. So this is great. Okay, let's go next page. Okay, so now here we have something labeled as Adh approaching Dcis, right? So let's look at that. Oh, this is the same thing that we saw, right? So, I mean, you see the problem here, right? I mean, the other one that we just saw, where the changes were really the most advanced among all the slides that we saw so far, with multiple, foci of markedly atypical changes, that was called highly atypical. But here, I mean, a lot of this stuff is benign, clearly, right? And yet, people are worried here about, reaching the level of DCIS. I mean, so that says it all, really, I mean, to me, this is just, maybe some ADH in the background of sclerosing adenosis, or maybe some papillary kind of component, growing within. So I don't think this goes anywhere close to DCIS. Okay, let's look at this other one. This again, it says approaching DCIS. So look at the scanning power here, right? So what is going on? I mean, are you really, really concerned about something terrible is happening here? I mean, look at all these cores, right? Most of these look like lobules, right? I mean, obviously we are going to go at higher power. I'm just telling you, in scanning power, okay. Okay. So yeah, so these changes are worrisome, right? Clearly, although the focus is small, the cytology itself is kind of worrisome. These look hyperchromatic. I mean, this is like clearly ADH, right? It's a small focus, but it is quite atypical. And if there was a lot of this in multiple cores, this would not be a problem, right? You would call this DCIS. But because here it's very focal, I mean, when we looked at the scanning power, we saw pretty much nothing going on, right? I mean, most of these are just benign lobules. So this is a perfect example of why you would want to call ADH. It's such a small focus. You don't want to go beyond ADH. So this is like a nice teaching case of what qualifies as ADH because the volume is so small. Now, if the nuclei were grade 3 instead of this kind of grade 1 kind of nuclei, if all these nuclei were really very pleomorphic, high grade nuclei, then all bets are off. Then we don't care about the volume. Then that is already DCIS. I don't care whether it is only one small duct like this. If the nuclear grade is very high, then that is DCIS. End of story. The whole debate and the headache is all because of these low grade kind of things. That is where most of the differences of opinion happen. And we need to recognize that. And also in ordering the stain, like something like CK56 and all, please don't order it if it is like high grade DCIS, I mean, you never know, that may be like a basal-like DCIS and the CK56 will stain. Or sometimes DCIS can actually entrap benign epithelial cells, right? Much like in pagetoid fashion, that is how pagetoid growth happens. So this can happen also in ducts, in a hyperplastic ducts. A high-grade DCIS might squash around and will trap all the benign proliferating epithelial cells. Now, if you do CK56, all those entrapped cells will stain with CK56. And you will unnecessarily call something as, UDH, although it is clearly DCIS. So you have to be a little bit mindful of how to use those stains and how to interpret those stains. Okay. Oh, we did already. Yeah. Okay, good. Okay, so I think let's move on. So let's, for the time being now, go to DCIS. Let's start our discussion on DCIS. See how these spaces are very atypical here, and it's quite extensive. So again, in that previous slide, we saw similar changes, right? But they were only like small, very small foci, and that's why that was called ADH. So there's not much in terms of molecular or morphologic changes. The real classic ADH and low-grade DCIS are the same. It's only the volume that makes the difference, and that is where the arbitrary 2 millimeter rule and all came about. So the same set of changes are happening as in the previous case, but the amount of changes are so much that I don't think anyone will doubt that there is, this is good enough to call DCIS, right? You can defend this even if the excision doesn't show anything. And surely the excision in such cases will show more. Okay. So here we have DCIS and LCIS. Let's see. Okay. So the scanning power is very good. These days, whoever, now that we are doing more and more digital kind of pathology, suddenly this becomes very handy. This kind of scanning kind of, visibility at scanning power is not possible in our microscopes, right? But now with the digitization, so it becomes very easy to really just focus on where the money is. So the question really is there any DCIS here? Or is this all LCIS? See, I was telling you that sometimes, collagenous ferrulosis can happen in LCIS, and lo and behold, we just got to see this is all LCIS, and this is all collagenous ferrulosis. See this membranous kind of thing. All this is collagenous stuff, and this is an artifactual pulling. This is not a cribriform space as seen in DCIS. This is all because of this collagen material deposition. And this is a classic way of recognizing that this is collagenous. When you see this kind of membranous kind of stuff being pulled away from the periphery towards the lumen, that is virtually pathognomonic of collagenous ferrulosis. So all this stuff, all these spaces really is collagenous ferrulosis within LCIS. See how much remarkable it is. So, to me, there may be DCIS somewhere which we are not seeing, but here in this field, at least this is all LCIS. And really the stain that you need to do here is ecadherin. Ecadherin would solve your problem. I think whoever is posting this picture is going to come and kill me.
Should we give this feedback to Dr. Rajendra?
No, it's fine. It's quite possible that in some other slide there is good DCIS.
Yeah.
Okay.
Yeah, that's what I am thinking.
So now this is again, now we are looking at scanning power. So clearly we are seeing the most abnormalities are here, right? So we'll go there. So no, there is no debate here, right? You don't get any prizes for making diagnosis of DCIS here. This is all like almost like, central necrosis, comedo type of necrosis. The nuclear grade is also, sufficiently high. This is more than low grade, intermediate already. Also the volume is, so in a situation like this, the volume really doesn't matter. Even if on core biopsy, you had only one duct like this or two ducts like this, you would have no hesitation in calling DCIS. So all that problem happens only when the changes are very low grade.
Dr. Giri, may I ask you a question?
Yes.
If we don't see collagenous spherulosis,
Yes.
can we, without ordering stains, distinguish between LCIS and DCIS? Can we just morphologically distinguish between the two if there is no
Yeah.
collagenous spherulosis present?
Right. If there is no if there is collagenous spherulosis. Yeah.
There is no, because you said if there is, then that's that guides us through LCIS. But if there is no collagenous,
sorry. Let me rephrase this. What I was saying is that collagenous spherulosis can sometimes happen in LCIS, and we just happen to get that illustration. The point was that in order to confirm the diagnosis of LCIS, instead of doing CK56, you would have to do E-cadherin stain.
yes,
That would confirm the lobular phenotype.
right.
If we had done CK56, that could actually create more problems, because first of all, it would be, if it is negative, you wouldn't know whether it is lobular or ductal, right?
Yes.
You would be working with the hypothesis that this is all DCIS or ADH, and therefore the CK56 is now going to support your presumption that this is DCIS, right?
Right.
But if you had suspected that, oh, could this be LCIS, and if you order E-cadherin, then you would make the diagnosis of LCIS.
Right.
Now,
yeah, my question was, without ordering stains, can we distinguish the two just by morphology?
by morphology, yeah, depending on your, see, there was no E-cadherin, right, 20 years ago, but these entities were recognized.
Okay.
Now, because we have these tools, it's probably a good idea to use them, because you want to have an objective measure of your diagnosis.
Right.
So it's not essential, depending on your degree of experience and all. You can still make a diagnosis of LCIS in collagenous spherulosis.
Okay, thank you.
Yeah. Okay, I think Akanksha, I'll stop here because it's already past 5 o'clock.
Yeah.
So we will continue tomorrow and we will try to cover more ground.
That's okay. You are doing very, very great. I mean, I have learned so many things so far from you, and I would love for you to be free and do at this pace or whatever pace you would like.
Yeah, I think that the whole purpose of these sessions is not to engage in some kind of textbook teaching. You know, I would rather share my perspectives and, you know, how some of these, you know, are important in our day-to-day practice.
Right, and that's why we have like some of us are like practicing since 1, 2, 3 years, and we still want to learn because we want to learn the perspectives of specialists who are doing it for some time.
And I do recognize that in this group, you know, there is it's a variety, right? I mean, there is a spectrum here, people with different levels of expertise and experience, and how much they do breast pathology and things like that. So for some, this may be quite repetitive and elementary, but I think my hope is that at least, you know, there will be a take-home message for many, many people.
Definitely. And I love the way that you, like have stories and tell us about Adh and all of the other big people and what they say, which is very interesting. So.
Okay, great. Okay, guys, see you tomorrow.
All right. Thank you very much, Secretary.